Next speaker is Dr. Edward Schneider, who is the Director and President of Veterinary Research Associates, a clinical laboratory on Long Island. And he will explain the role of the clinical laboratory in evaluation of Lyme infection and basically the domestic animal situation.
For the sake of brevity, we're going to try to limit much of what we say to the practitioners in the audience today as well as to the interested public. Some of the reasoning behind that is that one of the great problems I feel today with the diagnosis of Lyme borreliosis is the lack of educational program for the veterinarian in private practice. There is a limited amount of literature that is appearing regularly in the clinical journals. Those of you that are here that are in research can well appreciate the publications that you put together on a regular basis, the journals in which they're published, and the nature of the article themselves. Most practitioners, and this I would say a rather large number of practitioners, do not read research articles. They occasionally will get to an abstract, peruse it, and go on from there. We have very little appearing in clinical journals on a regular basis. From the standpoint of presentations at clinical meetings in areas that are even endemic for the disease, such as Westchester County, Connecticut, and Long Island, I'll speak for Long Island because I'm from there. We have had 2 lectures in the past 4 years relative to Lyme borreliosis. This is hardly adequate. State-of-the-art technology, treatment, diagnosis, nothing's being mentioned. Most practitioners out there now are flying by the seat of their pants. We take a look at areas that are heavily endemic on Long Island, especially the eastern end, and we take a look at the practices there, practices of similar size, in which one particular practice is ordering a rather large number of serological procedures on animals, and a fellow only 2 miles up the road within the same area is ordering virtually none. During the quote-unquote testing season, we hate to use the phrase, but most people assume that there is a testing season, and that's the time that usually extends from April through October. During the period of time from May until the end of August of this year, our laboratory tested approximately 5,000 samples for Lyme borreliosis, 53% of which had titers that were positive for the antibody. And I think Dr. Burgess probably cleared that earlier. We use the same technique, which is an IFA technique. And we draw a line at 1 to 64. Anything less than 1 to 64, technically with lack of appreciable antibody. At 1 to 128 or greater, presence of antibody, and at 1 to 64, marked equivocal. Of all the cases that we were able to investigate, and I selected about 1,000 with the cooperation of several practices, 69% of these cases presented with the classical arthritic-like or arthralgic presentation, be it single joint, multiple joint, or whatever. That means that if we can still subtract 69 from 100, the balance are not being presented with arthritic-like disease. And in discussions that I've had with many practitioners throughout the region, they're really not looking at anything else that is not presenting with an arthritic-like syndrome. 11% of the cases were asymptomatic. These animals were being tested either based on the fact that there was an additional animal in the household that had tested positive and been treated for Lyme's previously, an owner with Lyme disease, or just a person that was in the area that was concerned. This is 11% of the 1,000 cases that we reviewed that were asymptomatic and carrying positive titer. It's also interesting to note that the asymptomatic animals uniformly ran higher titers than the symptomatic. We were averaging titers in IFA of exceeding 1 to 512 on a daily basis on asymptomatic animals. The other groups, the usual inappetence, lethargy, lymphadenopathies, and the lymphadenopathies that we encountered were without exception prescapular. Those that were examined by aspirate or section were unremarkable. GI symptoms, gastrointestinal symptoms, amounted to 2% of the cases that we were involved with. Profuse diarrheas. In several cases, we took a look and saw the way the veterinarian was approaching the diagnosis with differential diagnosis, that the routine fecal examinations for ova and parasites, Salmonella, Shigella, Campylobacter, were done, that the usual possible viral entities, parvovirus, canine coronavirus, were taken into consideration at the time. But 2% in GI symptoms is a rather large number. Upper respiratory, exclusively upper respiratory, I should really hedge on that a little bit, because of all these cases, 15% were febrile. Of the 1,000 presented, 15% were febrile. The upper respiratory cases, which were, again, 1%, but in this case, about 98 cases in this one study, or in the second study we did, amounted to 1%, and these were various and sundry upper respiratory infections. What we're trying to get at this point, and it's really pull at somewhat the heartstrings of people out in the eastern end of Suffolk County, is they haven't been able to get a lot of answers. They're out there on a daily basis wondering about this. They have numerous cases out in the area. I'm more concerned about the veterinarians out there that are not recognizing it. And it's a recognition that's due to lack of understanding of the disease, or is it due to the fact that someplace along the line, people that should take a role in the educational process or the continuing education process have failed to do so? What I would like to do, because we do have a number of people here, prime interest people, lay people, and practitioners, I would like to open the balance of the time that I have into an open forum discussion on what is going on, what they want to know, and how we can respond to it. The laboratory, I feel, nowadays has a greater responsibility than merely providing a number to a practitioner. If there is any amount of expertise within that laboratory, I believe it is incumbent on those individuals to be out there in the field by telephone or virtue of publication directly to the practitioners in private practice on a regular basis. I haven't seen this done. I know it's not being done within the tri-state area, the area that we serve, but I think it is something that is critical now to the diagnosis of Lyme borreliosis. It's not happening. So what I would like to do is to take the balance of my time, throw it open to the practitioners in the audience and to the lay public, and let them fire away and see if we can handle any of the questions that have been on their mind, things that they have possibly asked and not have been given satisfactory answers to. So I'd like to do that as of now. Sir.
What do you think about
General opinion right now, at least within our area, is that by next year it is going to be as common to test for Lyme borreliosis in endemic areas as it is to test for heartworm in a dog or do an FELV on a cat. It is getting to that point. We know of the cases that we've done, and which number several thousand, that other tests are being done by other persons on a regular basis. Goodness knows how many thousands. If this percentage varies, that I can't say. We're running at 53%. What Dr. Burgess had mentioned to me in a telephone conversation a couple of months ago is that she arrived at an identical figure in Wisconsin. But I do believe that it's going to be a routine procedure in endemic areas. Bob? At this point in time, culturally, I don't think you stand much of a chance. You're still talking about a good length of time. I think the only other possibilities exist would be if you can pick up the Borrelia in a particular fluid and stain it with monoclonal antibody. There you might be able to pick it up and work relatively quickly. From the standpoint of culture, we don't stand a chance, not for a while. Not with the ability to provide rapid information so that therapy can be instituted. Not at this point in time. I think we're talking at the best on most cultures, and depending on the laboratory, I guess I'd be able to bear that out, you're talking at least a couple of weeks in most cases.
Yeah, suppose I might as well chime in here. The culture media itself that we use now is very rich, very expensive, but the spirochete is the last one to grow. Everything else grows before the spirochete we're looking for. The only way I can see bolstering that media is to put something like egg yolk, high lipid content into it. They seem to like the lipids. But still, you have to wait on the spirochete to grow. And we've had cultures that have required between 63 and 95 days just to come up. And this is from a white-footed mouse, which has more spirochetes than the dog probably would. As I see the ultimate, if it is being shed in the urine, I have not seen it in the whole state, like Betty has. But she did send me her organisms. I have them in culture. They seem to multiply, but they're non-motile. So I think somehow along the line they're damaged. But if they're damaged, that means there's probably some proteins from that organism in the urine as well. If we can determine which one, it's probably a rapid shedding process and probably some monoclonal antibody directed toward a spot of the urine or a protein located in that urine would give you an early diagnostic procedure. That's what we're working on now. And it's not as easy as it sounds because we've been working for 3 years on it. But that may be the ultimate for earlier diagnostic procedures. Does that sort of address what you were asking?
One of the other questions that had come up earlier in the day had been on the number of cases of central nervous system involvement. And actually, of the cases that we've seen, we've only had 2 that were presented as spinal fluid. And both these cases, the spinal fluid levels were both at titers of 1 to 128. We didn't have much data on it. In this particular instance, the owners elected in both cases to euthanize. We didn't get much further on with the project on those. We have to address something else when it comes to therapy.
and a lot of people don't like to hear it, but it's true. In veterinary medicine, unlike human medicine, there are certain economic constraints. Certain of the products or certain of the antibiotics that might be utilized are highly expensive. There are individuals that are willing to go the full route. There are others that are not, and as a consequence, we're seeing a lot more animals euthanized with Lyme borreliosis than we had anticipated. It's not a nice fact, but it's a fact of life. We don't have third-party billers. There's limited amount of, insurance coverage is virtually non-existent. So if we're going to talk about long-term therapy, especially possibly with third-generation cephalosporins, we're talking about some very large dollars involved. It depends on the individual, their attitude towards their animals, and whether they're willing to go this route. Like I say, I've been quite disappointed with the fact that many people have elected not to, and we've seen euthanasia in these particular cases increase substantially over the past year. I don't have a heck of a lot more to say, but the one thing I have to impress on everybody is when it comes to the laboratories that we recognize that the interpretation, evaluation, and the analysis of all laboratory data leading to any course of action is still the prerogative and the professional responsibility of the attending practitioner. Laboratory data is still supportive in nature. We wish that we could be 100% specific. Too often we must equivocate. We don't like to equivocate, but we have to equivocate. Under those conditions, we're talking about clinical impression. That's what you've been trained for, and that's what's going to have to be used. There are too many cases of so-called equivocal titers, marginal ones, that are not going to support the diagnosis. So you're going to have to go strictly by clinical judgment. They're not there. The laboratory is not going to try to practice it. It's going to try to lead you in whatever direction we can to provide you with the best data that we possibly can. But it is still the ultimate responsibility of the practitioner to see the case for what it is, make his own judgment, and go on from there. Sure. It's very, very difficult to say. We came up with the 53% positive, which was actually, we didn't think initially it was going to be quite as high. When we, if we subtracted the 11% asymptomatic animals that were being submitted based on more on client request than on the request of the practitioner, then that percentage ultimately will change. We don't know, in all honesty. We've had calls, and I would imagine that we answer about 8 to 10 calls a day relative to Lyme borreliosis on a day in our laboratory. Goodness knows what goes on at Ed Boswell's lab or at any other lab around the country. Doctor. Broad-based screening of disease area is there now. You should be at it. And I think this is going to happen probably by the spring of this year.
Most of the veterinarians that I associate with are testing all already made or using maximum surgical molecule that is not necessary for more so they're screening, they go positive 12. Number one, the animal must be public health the area on Long Island where third-party partner material. So toxicity 70%. Quite quiet throughout the round, but it's very high. I think that's a morally useless. I guess I am going to have to talk. So why is it consistent positive well? One thing is we don't know many areas that in fact hopefully absolutely I'm afraid this is in line with you take a look again here at Railroad down here. And because certain portions of the island are really suburban schools, single family homes, there's lack of woodland in the neighborhood. There is endangered to life practices on down here, areas of things that all have where they have nothing to fear relative to liability. If any of them fail to realize this a couple miles down the road, we're not going to get into the language discussion on pictures, fishing rights, and birds. We know about the possibilities of possibilities today. But again, that's one of the reasons why much of this is being overlooked. If they get out from an area that is not ideally set up for a picture book presentation on an area where ticks and other vectors are infected, everybody is just looking the other way
And making believe that this will not happen in their area. I'm afraid that we're in for a rather substantial shock when we start developing advanced cases of Lyme borreliosis within those particular areas. If there are any other questions I can answer, I want to try to compress anything else now into another minute or so we can get on with this and we can fill the balance of the time with other speakers. Do I have any other questions? If not, I'd be glad to answer any other questions after.
The next speaker who will discuss the epidemiology of Lyme disease in horses and the potential public health significance, Dr. Daniel Cohen from the New Bolton Center and also from downtown now. He's the Associate Dean for Research in Philadelphia from the University of Pennsylvania.
Thank you, Ed. Before I begin, I would like to take advantage of the podium just to make a brief remark. I attended, just prior to coming here, a symposium at the New York Academy of Science that was just held at the beginning of this week on Under the Volcano, Biomedical Science in the Third World. It dealt primarily with the problems of tropical medicine, essentially parasitic diseases, and their growth, particularly under the impact of AIDS in the Third World. And one of the most impressive things that was presented were some of the newer bioengineered products, both in the diagnostic field and in the therapeutic field, which are emerging in this war against parasitic organisms. And I believe that a lot of the, as I listen to the discussions of Lyme disease and some of the technology we're still dealing with, we're essentially dealing on what is a very primitive level in comparison with some of the newer forms of diagnostic and therapeutic techniques which will be emerging. So I think we should keep an eye on this. I think the answers are going to be in molecular biology. I think one of the last questions about do we have better ways of identifying the organism? We don't have to identify and actually see the whole organism. We only have to see some of its DNA sequencing to be aware of its presence in tissue, etc. And this armamentarium is being reduced to very practical levels for transfer to the third world. And in that transfer, it makes possible in our diagnostic facilities a new armamentarium, and I think that's just on the horizon. So with that just as an introduction, not even an introduction, I want to talk about equine problems. And essentially, what I would like to do, ever since Marcus in 1985 at Tufts University first made us aware of the fact that there are a certain percentage of horses in endemic areas showing titers to Lyme disease, and followed shortly thereafter in 1986 by Burgess showing equine disease, Lyme disease in a pony. We became interested in this problem. Actually, our interest came about through an unusual clinical event. I was working at the New Bolton Center, which is large animal, probably the largest equine clinic in the United States. We hospitalize better than 5,000 equine cases a year, and that's a very substantial caseload for an equine practice. And I'm not discussing the outpatient, that's just the inpatient practice. So we see a lot of horses. And the clinical event was presented to one of our veterinarians of 3 horses on a breeding farm in New Jersey with cardiac arrhythmias, 2 mares and a foal. It's a very unusual event. We have cardiac arrhythmias in horses, but we rarely get clusters of these cases. And rarely do we pick them up in terms of time in a very short period of time on a single location. So we rushed out to that farm because we had just started to think about Lyme disease and thought perhaps we would have some good fortune there. Well, by the time we got there, the owner had gotten rid of those horses because he didn't want the stigma of having horses being bred on his farm with potential cardiac disease, and we couldn't trace those horses and they were gone. But in the process, to make the best out of a bad situation, we did some serologic studies and then decided we ought to have some controls over this. We approached that, and all of this work, all the serologic work is work that has been done in Ed's shop. So what I'm going to discuss now are from these early beginnings, serologic studies, how widespread is the disease? How widespread are antibodies? Never mind disease. How widespread are antibodies in equines as we've experienced them in our hospital, in our area, etc.? How long do they last? What do they mean? What are early clinical signs? We did some experimental work, and I'll show you some unpublished reports of our we will soon be publishing them, some of our clinical studies in ponies, which help us to interpret titers and tell us what it means. And then what conclusions do we draw from this? What does it mean to have a titer, and what does it mean in relationship to Lyme disease, and what does it mean for the future, and is the horse an important source of Lyme disease for man? Those are the kinds of things I'd like to touch on. So we can have the first slide. Yeah, good. This is a map of New Jersey. The initial farm that we went to for our studies was located in the southern part of the state, in this area. It's an area that has had reported Lyme disease, but not as much as this area of the state. For our controls, we went to a farm that was up in this area of the state, not knowing at that time what the situation is with human Lyme disease. So we will see first, there are two farms that we are going to be discussing. One in an area that we would consider endemic, but not highly endemic, and then the second in an area that is considered endemic. Some of the results were rather startling. So can we have the next slide? Can we just dim the, is there somebody who knows how to dim the light? Just to give you an idea of what the terrain is like. This is in the continental shelf of New Jersey, central New Jersey. The farms have grassland, all with wooded borders to the area. Good tick country. And subsequently, we have learned that in this area, 50 to 60% of the ticks on this particular farm carry the spirochete. Just to show a comparison between IFA and ELISA test, these are IFAs and ELISA tests done on horses, and you'll see that there's pretty much of a straight line relationship. We called arbitrarily, as we started our study, everything on the ELISA that was 1 to 200 and over, we considered positive. And everything below that, we considered a negligible or plus or minus or negative area. And you'll see that everything substantially from 1 to 64 and above on an IFA was equivalent to 1 to 200 and above on an ELISA. We'll come back to that because we learned to our chagrin later that this is not necessarily true. Next one. This just shows you the straight line relationship between the two, so there's good coordination. Farm A is a farm in a highly endemic area of the state. Farm B was the original farm we went to in the southern part of the state, and you'll see that on our survey, we turned up about 12% of the animals on that farm showing titers. This is what originally got us excited about the disease. But when we went to Farm A and did our study there, we found that about 50% of the animals on that farm were showing these titers of 1 to 200 or 200 OD and over on the ELISA test. When we broke it down into the different categories for comparison, we found that on the original farm, 4% of the yearlings showed titers to Lyme disease and about 18% of the mares. When we went to Farm A, we found that 60% of the yearlings and 60% of the residential mares and 66% of the stallions, those that were in residence, about 60% of all the animals that were resident on that farm had titers to this disease. Whereas those that were visitors, that is, animals brought in for breeding, had the same 14%, which was comparable to the 12% to the 18% of Farm B. So Farm A is a hot spot for whatever reason. Can we have the next slide? When we looked further and made our comparisons on Farm A, between Farm A and Farm B, essentially the difference, of course, is in what's happening with the yearlings. We tried to see if there was any other comparative signs between the two age groups where there was increasing attack rates with increasing age, but we couldn't. The numbers were not sufficient for that purpose. But if we had to characterize the difference between the two farms, it was the attack rate or the seropositive conversion rate in the younger animals, being a low order on the farm in the less endemic area, and in the highly endemic area being about 60%. Next, please. We then took a look, this sort of summarized the first part, 60% in the Farm A, 14% in the visiting animals, 12% in southern. We decided to look at farms in our area. We found that this famous 12%, or about 10%, shows up in the farms that are coming through our area. We examined the University of Pennsylvania Hospital in 2 different monthly periods and took a sample, random sample, and we found that 12% of the animals coming through our clinics for all purposes, regardless of their location, had titers of that order, the high order, in the month of June, and this was reduced to 6% in the month of October. But on the average, we had about 10%. Famous same 10% that we see in the other animals coming from less endemic areas. So about 10% of the general population is running around with titers, and in hot spots can go up to about 60%. Can we see the next slide, please? When we tried to analyze this for location, these are animals that we could follow back. most of the antibodies, about 18% of them, were coming from the state of New Jersey. Of all the animals, we see primarily animals from New Jersey, Pennsylvania, Maryland, and Delaware. And of the animals that we saw, New Jersey was contributing the large percent. This was significantly different than those coming from either Pennsylvania or from the other areas. However, we did not see any correlation between seropositivity and any clinical sign. They came, seropositivity occurred across the board, and there was no particular association between seropositivity and any clinical presenting sign. Next, please. The question came up, is this a new phenomenon or not? Are we seeing an increase in antibodies in a particular area? Going back again to Farm A, which gave us 60% antibodies today, what was the seropositivity in 1983? We had sera from 1983, collected for another purpose. We went back. We also had on yearlings and on mares, not necessarily the same animals, but on the same groups of animals. And we found that in 1983, the yearlings were at about half the rate that they were in 1986. The mares in 1983 were at the famous 10 or 12%. In other words, they were at already the basic endemic rate, but the mares, that same age grouping of animals in 1986, were at 60%. So they showed a 5-fold increase between 1983 and 86. Next, please. How long do these antibodies stay up? I mean, are these antibodies short-lived? Do they fall in the horse? How can we start interpreting data? Well, the first crude cut at it, we looked at animals in March, the whole grouping of animals on that one farm in 3 different times of the year. And as you can see, there's a drop-off from about 53% down to about 35%, a drop-off of about 30% in the general groupings over that 6-month period. However, when we followed specific animals through, can we see the next slide? These are animals that are matched. These are the same animals followed in March. We followed them through July to September, and I'm only looking at the March to September results. And in 60% of them, there was no change in that 6-month period. 5% of them actually increased, that is, were re-exposed, and 34% of them decreased. So about 1/3 decrease in a 6-month period of time is what we would expect. Next, please. We took some ponies and infected them with Lyme disease. I will show you the full study, but one of them, initially, we followed through a period of just to get an interpretation of what the serologic titers mean. And this slide shows the results of infection of a pony with tick material that had Lyme organisms, Borrelia organisms in them. And to our surprise, when it was evaluated, you see that this original increase in titer is below the ELISA test of 0.100. We were considering 0.200 as being the cutoff point. And you can see that the initial response to infection is of a much lower order. It dropped off essentially to 0 by about 6 months, 180 days. We reboosted this animal, gave it a single shot of primary culture, and it immediately jumped up within days, 1 or 2 days. It was up to a very high point of about 300 and 400 on our scale. So we are now understanding that from this material, that the initial infection gives a primary exposure, gives a very low order, which may be missed by many serologic tests, or very difficult to distinguish this response from essentially a negative or plus minus. But re-exposure gives a very significant response. And undoubtedly what we have been dealing with in our serologic studies are animals that are under constant exposure and re-exposure. Next slide, please. Now, we had some clinical experience. We went back to this farm and said, did you have anything unusual going on these last few years that we ought to know about? They said, well, now that you mention it, yes, we do have some problem. And that problem essentially was something that is very mild and seemed to take care of itself, so we haven't been concerned about it. But our foals started to come down on certain pastures, started to come down with edema, swelling of the legs, and some dermatitis at the base of the legs. They don't seem to do very well. Then this lasts a very short period of time, sometimes a few days. Some of them we give antibiotics, it helps. Some of them we don't give antibiotics, it doesn't seem to matter, and they recover and go on. So we asked him to start. Fortunately, this farm was owned by a veterinarian who had very good clinical records. And so we went through his records and we plotted the events. There are two different farms on which he has his establishment. And on one farm, you can see the incident started in September, ran all the way through to the mid-October, and it seemed to be spaced out time-wise. On the second farm, we had what seemed to be a clustering of cases, and we tried to get a little more information about this farm, and apparently these animals were clustered because of the time, were put into a shed together and maintained in one shed for an additional week before they were put out on pasture. So at weaning, they were taken and put in a confined area, and this was the result. Can you have the next slide? And what essentially, when we plotted the week of onset, you see it looks like a point exposure, which was our first inkling that there may be something more than ticks involved in transmission. We were getting essentially what looked like a tick-borne or vector-borne transmission here, and here what looked something like very similar to a point source outbreak. Next slide, please. Clinically, the cases, as you can see, this was with dermatitis and edema, lasted only 4 or 5 days. He was giving antibiotics at this stage. The subsequent year, he didn't give antibiotics, didn't change anything in the history of these cases would clear up by themselves. Nothing very dramatic about it, but you'll see that not a very important problem, he thought, that first year. The next year, we started to follow them again. Can we have the next slide, please? And this is the second year. In the second year, he had 2 cases that developed the frank arthritis. These 2 we started to call arthritis, but I'm not very sure about that. But these 2 persisted, one for at least 43 days. And this animal, when it had to be sold, which was 6 months, almost a year later, still had chronic arthritis of the limb, and we did recover antibody to Lyme organisms from this animal. So this animal was a loss to him. This animal did become lame, and it is the only one. All of the others were rather mild. But again, if we can have the next slide, the overall attack rate for this problem in his herd was fairly substantial. So although we like to think of Lyme disease in horses as an individual case, and the Lyme disease in cattle as being a herd problem, this is not necessarily so. In industrial equine farms, if this progresses as we believe it will, and I must say that he's now into his 3rd year and he's having these cases again. So this time we're going to follow them all the way through, and we may see more than we expected. But he was getting 19% of his foal flock crop were affected the first year, and 14%, almost 15% the next year. We have the next slide, please. Well, some of the swelling of the legs, limbs, nothing very dramatic. Can we have the next slide, please? Some with dermatitis, and incidentally, the reports from Britain in a book I read on veterinary diagnostics, which claimed that a condition that veterinarians know as scratches, which is a dermatitis of the white areas of the lower limb, that spirochetes have been found in Britain in these lesions. So whether this is a Lyme lesion, dermatitis or not, remains to be proven. Next, please. Again, an animal with the painful lower joint, reluctant to put it down. Next, please. I'd just like to, in the remaining time, go over some of the experimental work. In order to interpret all of the results of what we are seeing and to prepare ourselves for future work, we did a quick and dirty experiment. We took 6 ponies and confined them in pens in which they had contact, head contact, and even water trough contact between the 6 ponies. 2 of them received tick inoculum. 2 of them received primary culture inoculum, that is cell culture, the first without passing of spirochetes. And then we put 2 uninoculated controls in between. May I have the first slide, please? Next slide. This is the original pony that I showed you that had converted. This is the same one that we saw, which had a small spiking, then continued along. Then we re-exposed him. He shut up. And you'll notice that as a result of the re-exposure, he lasted, the titer fell essentially to negative in about between 180 and 300 days. 120 days later, that animal went from positive to completely negative. So if you want to know how long the titers will last, this is a very good indication of how long. We know exactly when he was exposed, exactly when he was re-exposed, and this is the duration of antibody persistence. Next slide. This is another pony, which was the mate of the one that you saw, that received tick material. He stayed essentially uninfected, or at least no serologic response. However, at post-mortem, this pony, as well as the other one, showed a very high number of of cells in their cerebrospinal fluid. So whether they were at the beginning of neurologic disease or not, we don't know. We sacrificed these animals at almost 320 days. That's almost a year. And up until that time, this animal stayed asymptomatic. He didn't even respond to being re-exposed to the organism. He just seemed to be uninfectable. But at post-mortem, the only thing that we found in complete examination of this animal was that he had a high count of cells in his cerebrospinal fluid. Next slide, please. This is two of our ponies did develop signs of hepatitis. And I was interested as we saw this. We were looking for arthritis and we were looking for uveitis. We're not looking for hepatitis. One of the animals developed jaundice and had a very high SGOT or AST levels and high liver enzyme levels indicating hepatitis. This animal showed initially a sign of serologic response to infection, and then at about day 80, just about the time when it started to show clinical jaundice, it also showed an increase in antibody level, which again was of a low order. We would have missed it at our screening of 0.2, went essentially down to negative, and stayed that way through the course of the disease. This animal ended up with frank cirrhosis of the liver. The second animal, next one please, was the other pony, 251, showed a slight spiking initially after being, again, these were exposed to primary cultures. About 800,000 organisms were given to these, spirochetes were given to these animals in multiple sites, IV, sub-Q, intramuscularly, etc. You'll see that he stayed essentially negative through the whole period. This animal had subacute hepatitis. We only picked it up because the other one showed frank signs, and we checked the serum enzyme levels, liver enzyme levels of these animals was also very highly elevated. And then by liver biopsies, we found a mild hepatitis. He never progressed to a cirrhotic liver. The other one did. The difference between these two ponies may be due to something else. We sent some of the material to Barry Blumberg's hepatitis laboratory, and in the pre-inoculation serum specimen that we obtained from this pony and the other pony, the previous pony that developed jaundice showed signs of having some non-A, non-B antigenic material. So it may have been, there is a disease in horses called Tyler's disease, which is a hepatitis. The etiology has not been, etiologic agents have not been identified. Viruses have been suspected, but not isolated. And what we may have is that under a combination of viral antigen or latent virus plus Lyme organisms, we get the emergence of a clinical syndrome, which ends up having an animal that's jaundiced and infected. So Lyme organism working by itself may produce only subclinical hepatitis. And this fits with some of the human studies in which not subclinical, but very mild hepatitis without cirrhosis, cirrhotic or dramatic changes, without jaundice, has been reported by Steer, and today Dr. DeRay mentioned it. So we may be seeing the equivalent of that in these ponies, in these horses, and we may be missing it. So we are now looking, every time we have a case now of suspected Lyme disease or any of these other signs, we also try to check for serum enzymes. Next, please. Most startling thing of this study was something we didn't expect, we had hoped for. One of the ponies that was an uninoculated control placed between the two inoculated animals. On one side was the animal that was jaundiced. On the other side was the animal that received tick material but showed no clinical signs throughout the study at all. This is an uninoculated control, and about the time, you remember I said about 80 days after exposure, the hepatitis was seen in the ponies. Shortly thereafter, this pony spiked a very high antibody response. Again, no clinical signs. Checked his liver enzymes, stayed normal. We have no other information about him, except that at postmortem, this pony also showed a very high, almost a tenfold increase in the number of cells in the cerebrospinal fluid. So perhaps if we had kept him longer, we might have seen some neurologic signs, but we did not hold them long enough to see. So these are the teasing things that we got from our experimental studies. I think that one of the problems with Lyme disease in animals remains that we don't have a good animal model. There is no animal that duplicates all of the signs of the disease in man. Our inoculation of animals did not give us the arthritis and the ECM-like lesions, etc., that we had hoped to see in the horse. People have tried this in the dog. We're all having the same experience. We do have some suggestion here of direct contact transmission. There is no reason why this animal should have spiked such a high antibody response except as a result of exposure. And we don't know why we are unable to produce or duplicate the signs of the disease experimentally. They have certainly gotten heroic doses of the organism. But there's enough here to tell us that we're on the right track and that we have to look at this. And can I have the last slide, please? This is the other negative control, and nothing happened to him and just seemed to go. He spiked a little peak here. He may have also been exposed, but we didn't see anything dramatic in him. Next, please. This is my favorite picture. I show this wherever I go. This is not a horse with Lyme disease. This is a horse with everything else. He may also have Lyme disease. The problem that we have in this business, and I urge a great deal of caution about the association between clinical signs and titers. If we have anywhere between 10 and 60% of the animals in a particular area running around with serologic titers, you can make all kinds of non-statistical, invalid associations of clinical signs with titer. It's not going to be enough for us. We're going to have to develop a better armamentarium of tests that are more specific for the presence of the organism. We're going to have to know a lot more from experimental work what this agent can do in animals as well as in man, and I think that's the direction we have to go. I thank you. Yeah. We started in, the question was, what time of the year did we start these ponies? We started them in November and ran through until the following November. They were inoculated in December, but we brought them into the area where they were confined in late November.
I was reading up that was the possibility of any mosquitoes
Yeah.
in the room.
We hope not. What we did was we sprayed weekly, which is about the maximum we could do with the insecticide. They were placed in an inner area. Nobody was allowed into the area except the experimenters. And theoretically, there should be, we saw no evidence for vectors. Okay?
Okay, I think what we're going to do, it's 4 o'clock now. People have planes to catch, etc. So I would prefer if we skip the break, drop me. I will make some statements. Actually, most of my talk was covered by the other people. All I was going to show were some, blots to get across the point that the organism is persistent, particularly in asymptomatic animals, dogs and horses. You get a positive serology and you get a blot pattern that far supersedes the number of proteins that are reactive in animals than you do in humans with chronic arthritis of even three years duration. And then these animals become clinically ill. So that was one of the points I was going to make. And the other was that the classical symptoms, and perhaps we are somewhat to blame on this, the clinical case in the dog that we first described, the symptomology was lameness, anorexia, and it was febrile. And I think maybe, and Dr. Schneider sort of called this to my attention, not directly, but by his talk, because maybe we gave the misrepresentation that those were the only symptoms we saw in the dog on Long Island, and perhaps this would led the veterinarians off on the wrong path. Now we're seeing that there is significant neurological involvement in dogs. We have positive serologies from CSF. They blot out beautifully, and this must be intrathecally produced antibody. So the organism is taking up residence in the brain of dogs. And we've seen this range from very aggressive behavior to just slight behavior changes in dogs. Also, the renal problems are in the forefront in canine Lyme disease now. Had several deaths due to renal failure, and the only etiological agent that has been implicated by all types of tests has been Borrelia burgdorferi. So if anyone would like to talk to me, I will be here. The paper I was going to deliver actually is in the New York Academy of Sciences Annals, so it's already in print, so it can be read. But if you'd like to go back and get something to drink, feel free, but I'd like to have George Korch come up and present the military's experiences and programs, etc., for Lyme disease. And then Mr. Lynch from the State Park Service is here, or the Office of Parks and Recreation, and he will be the final speaker. And I think we should get out here by 5.
Well, whereas I'm in the military, what we're going to do right now is we're all going to get up and do 40 or 50 push-ups, okay? We'll all wake up. And, well, not that anybody put anybody to sleep. I don't want to give anybody that impression. I think some thank yous are in order, at least on my part, to several of the researchers here. The military has just recently come into its own as far as Lyme disease is concerned, or that's maybe a little bit premature. We are coming into our own, as it were, through the assistance of several very generous individuals. Ed Bozer being one. Paul DeRay has assisted us. Alan Barber, Andy Spielman. All of these different researchers have helped us to get where we are today, and we are very dependent upon them. Have been up to this point, and thank them for their generosity. In terms of, I was told to present something in terms of the governmental response to Lyme disease. And we looked for several larger bureaucracies, but IRS and the Social Security system were unable to come here today to present their Lyme disease work. So the Army will have to do. And the Army, to my knowledge, this is probably the first presentation. Actually, now I know it's the second presentation at a national conference or at a borreliosis conference by the military on their efforts. The first one was given just a couple of days ago at the Pfizer meetings, and wouldn't you know it, I was beaten to the punch by a full-bird colonel, so rank still does have its privileges here. But can I have the first slide, please? Lyme disease is not just a public health threat to the general population, it's also a threat to the military. And to that end, we have been involved along several fronts to determine what impact exactly it has. We have concentrated a number of these efforts along various different lines, and what I'll focus on primarily today is our educational package that we've put together, and that, as you'll see, probably has a great deal of use not only within the military but outside as well. This is to help define the problem for the Army, because aside from the minor difficulties that we face in Lyme disease, like ubiquitous, highly infected tick populations, failure of antibiotic therapy, some of these minor problems, these are additional problems that the Army has. And to define the problem for the Army itself, what we have is a problem of, number one, the size of our workforce and where it's distributed, not just across the United States, of course, but we have troops or personnel distributed around the world. And we haven't focused necessarily on problems outside the U.S., but that's something that we in the military have to be considering. The population that we're dealing with is highly mobile. Imagine, if you will, you're a doctor on an Army base, maybe somewhere like Fort Bliss, Texas, and a new trainee comes in from Fort Dix, or better yet, you're an attending physician in Korea, and you have somebody that's just transferred in from someplace in an endemic area. So our physicians have to constantly be on the lookout for diseases that may not be endemic in the regions that they're working in, but are going to be important because they will make up some of the larger profile of illnesses that they'll be seeing. Fourthly, we have training requirements that put us in constant exposure, threat of exposure. Part of the workings of the Army are to get out there and to grub around in the dirt, as it were. And of course, in doing so, you come in contact with the vector population. So that's part of the job that we have to live with and that we have to deal with through public education. And then finally, we also have the need to not only look after our soldiers, but also dependents and retirees. This is just a quick breakdown of what our population looks like. Military as of 1968, you can see I don't have to read off the numbers, but the important point is, as far as Lyme disease is concerned, we have had cases in each one of these subsegments of the military population. This is just a quick distribution of where our troops are stationed in relationship to endemic areas of Lyme disease in the country. As you can see, we have quite a number of people. These represents thousands here. That's what the K represents. And most of our training does take place in areas where Lyme disease either currently exists, such as places like Fort Dix, New Jersey, or in areas of the country where we think Lyme disease may be spreading into. One of the particular areas of importance for us happens to be the southeastern United States, which is really the bulk of where all of our trainees go to receive their indoctrination. Our response so far to the problem has been basically along three lines at present, to include, number one, the establishment of a medical reporting system to the Office of the Army Surgeon General. The reasons for this are fairly obvious. It's important in order for us to determine just what the problem is, to gather those numbers, to be aware of what the scope of the problem is. And this is sort of a response in miniature to what we're seeing in the civilian population in general in terms of making Lyme disease reportable to the Centers for Disease Control. We began making this reportable to the Office of the Surgeon General in 1987. And I'll give you some statistics which we've accumulated since that point in time. Secondly, we've established field surveillance. And we have done this around the country. We have been concentrating mostly in the northeastern United States, and we've done some surveillance now for ticks and serology in southeastern United States, and we'll be soon expanding into the west. So as you can see, unlike many of the other researchers that are engaged in research in particular areas, we've got to be concerned with a broad spectrum all across the United States. Thirdly, we've been doing educational programs, and that's what we'll I'll concentrate on in a moment. And lastly, an area of big concern to us is going to be how to control this infection and how to control the tick populations on the installations. Many of the, or several of the people who have presented research here today have, in fact, performed their research on military installations. Paul DeRay, of course, at Fort McCoy in Wisconsin. Terry Schultze did a lot of his work in Fort Monmouth, or around the Fort Monmouth area. So this is one of our areas of that we will be going into. Our medical reporting system, as I mentioned, was established in 1987. From that date, we've so far accumulated 50 cases of Lyme disease. And I think the most significant factor in this 50 case accumulation is where our first case came from. It was identified in Virginia Beach area. It was a dependent who happened to be spending summer in Old Lyme, Connecticut. So true to form, we've at least initiated it in the right track. If you're going to be doing something, you might as well go to the place where the disease has been named after. So that was our first case on record, reported to the OTSG. But since that time, our cases have been accumulated from around the country: Wisconsin, New Jersey, Maryland, Missouri, Connecticut, Texas, Minnesota, and we've had at least one case so far from Germany. The important point to this slide is that despite our efforts, we know that there are many cases still within the military that go unreported or that are likely misdiagnosed. And so we're trying to beef up our efforts along those lines. And this is just a rough breakdown so far of our surveillance to date, showing various locations around the country and infection rates in the tick populations which we have surveyed on these various locations. If you notice, the southeastern United States, mostly these ticks were Ixodes scapularis ticks, and a certain number of other ticks taken from deer. This is all done mostly from deer populations, whereas as we creep up the eastern coast, we see a gradual increase in the number of infected ticks. Nothing startling here, but once again, with a sort of a nationwide surveillance effort that we're putting underway, we are, in a sense, corroborating the evidence that's been accumulated to date. And hopefully, with this sort of data, or with continuing the surveillance, if there are changes in the geographic distributions of ticks, we'll be able to pick up those sorts of changes. Or I should say geographic distribution of the disease. Okay, now on to public education. What are the advantages of public education? Well, we've seen so far that the agent is not really very flexible in terms of our ability to control it. I mean, it's pretty well established that it's a tough bug to control. The tick, from Terry Schultze's talk yesterday, the tick is a problem in terms of our ability to control that as well. So what are we left with in the triumvirate of agent, vector, and host? Well, what we're left with is changing the behavior of the host itself. And public education is the way we do that in this particular instance. And public education has the following advantages in that it's cost effective. We're not spending $1,000 per acre to treat. Most of the costs of reproducing either the slide series I'm going to show you or other forms of public education are by far less expensive than other control measures. Secondly, it's flexible. Third, we get a rapid return. In other words, once you've presented the information to individuals, you pretty much have at that point hopefully change their attitudes, change their perceptions so that they can deal with the problem. And finally, this control strategy, unlike others, has a certain longevity to it, in that unless there's a rapid flushing of the information, something should stay around long enough to be important or to alter to get the needed, the altered hope for effects. Okay, the educational package itself. Could you turn the slides up? Turn the lights up a little bit for me. I'll be demonstrating the package. What we've come up with is a narrated slide series, set of 40 slides, and I'm going to rapidly go through them very quickly. I know everybody's interested in departing for the weekend. 40 set slides, which are accompanied by two different audio cassettes. One audio cassette, which we've prepared for professional audiences, healthcare professionals, veterinarians, nurses, nurse practitioners, those sorts of individuals. And the second second audio cassette, roughly 17 minutes, so this is 34 minutes in length, this is 17 minutes in length, which introduce basically the ecology, epidemiology, symptoms, and personal protective measures for Lyme disease. We've also provided with these packages full documentation. By that we mean scripts. So you have the full script of what is on our particular audio cassettes, which allows the individual who will be giving the presentations the flexibility of selecting, picking, and choosing portions which they feel may be more appropriate for the audiences in question, and then tailoring the presentation to their individual needs. With this so far, the package that we've put together, we found that it has been widely accepted. We've gotten, at this point, we have distributed this to U.S. Congress, to the Lyme Borreliosis Foundation. They have made 20 copies of this, which I understand they're going to be sending out to the various support groups. We've had requests come in from the Fish and Wildlife Service, Department of the Interior. So aside from that, we've also covered the Army in that all 75 of our continental U.S. health clinics now own a copy of this slide presentation, so that the doctors as well as the patients are fully aware of the various aspects of Lyme disease. Really quickly, to show you what is contained in the slide program, we start out with chronology. The first module, as it were, is our epidemiologic module. And most of this is old history now to everybody sitting here. We have distribution maps, for instance. A lot of the slides, I should mention, come from various contributors who have also been very generous. Pfizer Central Research, Andy Spielman, Russ Johnson, the CDC series. We have incorporated from a number of sources, as well as producing our own set, so as to come out with a full package here. The vectors of Lyme disease, both potential and confirmed. Of course, wouldn't be complete without a shot of the infamous bug. Symptomatology. This is, I think, the second most famous leg in America. Therapy, and hopefully as time goes on, as more advancements are being made in the field, the beauty about this type of approach is that these slides can be changed, so that we're keeping a database of all the individuals who are receiving the package, and if a new therapeutic means is discovered, then this slide fits in nicely into the package, and we can keep this updated, unlike a videotape, which becomes a little bit harder to update. Of course, we then move from there into the ecology, and all of this is described in the actual presentation, the narrated portion. Things like the fact that the tick is very, very small. I mean, this is a comparison to the head of the pin here. I think this is taken from the Pfizer pamphlets. Natural history, of course, the white-footed mouse and its importance. And deer, this is one of Andy Spielman's backyard pets over here. Most people have seen this life cycle at this point, and it's been described completely here at this presentation by Dr. Anderson. And then we move from there into personal protective measures and environmental control measures. This really is the heart of the package, or of our educational program, because in reality, I think that the approach should be an ounce of publication is worth about a gallon of tetracycline, and for that reason, again, as in most of the publications that I've seen out here, we really are pushing personal protective measures as a preventive medicine approach to Lyme disease. And so these are all methodologies that you have already heard about here. Basically, since most of this had already been presented, I could have just gotten up here and say, now I'm going to talk about Lyme disease, and thank you very much. And the naturally proper dressing, or for the military, proper wearing of the field uniform. In those states which allow permanone, and with this package we do have a list of those states which have the 24C exception, or 24C permission for Lyme disease use within particular states. That is a part of this package, so that, for instance, for the Army, for individual installations, they can determine whether permanone can be used on their installation or not. Tick removal procedures. This is the slide that when I'm doing presentations to the public I have the most fun with, because what I will frequently do is poll the audience in terms of what they think the most effective means of tick removal are, and I've heard everything short of using a chainsaw to remove the tick. So, then we move into environmental control measures, which have some limited degree of effect, and as Dr. Schulze mentioned yesterday, really what's needed is an integrated pest management approach, but to at least inform people that there are some methods for control of the ticks. This at least addresses those issues. Habitat, for instance, where these ticks are going to be found. Surveillance methodologies. This is the highly technical tick drag method. Don't try this at home. This is a procedure that only real professionals should attempt. Or the dry ice method, and if nothing else, you can use that dry ice later on to chill your beer if you've not been successful. And then finally, my personal favorite actually is to utilize what we call the lint roller technique, which, to tell you the truth, may sound funny, but when you think about it biologically, if you're talking about an upright organism such as ourselves moving through brush, unlike a horizontal approach, assay technique, which we saw before, this probably has a greater degree of biological validity in terms of assessing how many ticks an individual will become exposed to while chancing through tick habitat. Oh, and this has received the greatest response. Actually, we're beginning to, our compliments or kudos to Westchester County. Just recently, I attended a meeting at Earl Naval Weapons Station around the Fort Monmouth area. They have a particular concern. That's one of our epicenters for Lyme disease in the military, and they've decided to incorporate this type of a sign into their prevention and control strategies. So these will be plastered basically all over the woodlands there, and hopefully this will have its intended impact. Of course, we also deal with the importance of pets, both in terms of the potential for exposure of their owners, as well as for the likelihood that these pets may experience some severe symptoms themselves. And while we have a captive audience, we don't fail to mention the fact that there are other tick-borne diseases out there which are important, and although we don't elaborate on these a great deal, this really stresses the fact that ticks are a public health threat, not just for Lyme disease alone. And then finally, of course, we bring this all back, at least for the military. You can leave this slide out if you want when you're doing, if you do use this package, if you're not interested in the military applications. But for our troops, it's important that they understand that a lot of the protective measures that we advocate are directed specifically for them in our personal attempt to change their behavior when they're dealing with infected ticks or the possibility of contact. And finally, I'm just going to say that the Army Medical Department has made some strides within the last year to address Lyme disease, and I think over the next couple of years we'll be seeing a lot more activity, both from the agency which I work with, which is the Environmental Hygiene Agency, as well as some of the other research and development arms of the U.S. Army. So maybe by this time next year we'll have some other control strategies, or at least an update of what's been going on within the Army as a governmental response to Lyme disease. Thank you very much. If there are any questions, I'll be happy to. I know the number one question I usually get is, where can I get a copy of that slide set? And at this point, if you're interested, please let us know. Unfortunately, because of the cost of reproducing these things, we can't just give them out and for permanent what's the word I'm looking for? On permanent loan. What we do is we loan them, you copy the whatever you need, and then you send it back, and it seems so far to have worked fairly well. So if you're interested in the set, I'd be happy to provide it, and within Berlioz' foundation itself, Karen has now made at least 20 copies of this, so there's another source for this slide package. Yes?
Any other branches of the military, Navy, Air Force involved as well?
Just beginning, yes, the Navy has, within the last month or so, begun to address Lyme disease. The Air Force also has. The Army obviously has been a little bit more active in the field, mainly because we have more people in field situations. The Navy, of course, does have installations that are in endemic areas. I'm not trying to make excuses why one service over the other, one branch over the other may have been a little bit further along. But at this point, we are collaborating with the Navy and with the Air Force so that with time, I think we'll all be operating at about the same speed. The Marines we never talk to, no. The Marines thrive on Lyme disease, I think, more than anything else. The Marines do fall underneath they fall under the jurisdiction of the Navy, so they will be, whatever benefit that has, the Navy will be covering the Marines. Thank you. Yeah, MasterCard and Visa.
Okay, the final, also governmental approach to Lyme disease would be protecting the public from high-risk situations in state parks geared toward New York State. And Dan Lynch, who is the Assistant Superintendent of the Long Island State Parks, where we have done some work very actively and in these types of areas, will provide you an update on what has been going on.
Thanks very much, Ed. One of the hats that I wear is that as Regional Safety Director for the Park Commission. We have approximately 500 permanent employees on our staff throughout Nassau and Suffolk County, located our state parks and our administrative headquarters. We have 15 state parks in Suffolk County, which is the prime area for Lyme disease in Long Island. However, we also have Lyme disease problems on the Nassau County border between Nassau and Suffolk, and we have 5 parks in Nassau County. In addition to the 500 permanent employees that we do have, in the summer, the Park Commission employs between 1,800 and 2,000 people, most of the young college students, high school seniors, or ones in between high school and college. About 2/3 of these approximately may come back the following year, and about 1/3 are new people who have never worked for the Park Commission before. I've been involved since 1985 with Lyme disease. I knew nothing about Lyme disease. I knew practically nothing about ticks, although my formal training back in the early 60s was as a wildlife biologist for DEC. The reason I became involved and interested was that 2 of our employees within a year's time came down with the disease, and I found out that some of the symptoms that they had, and it didn't sound too good, but I figured, well, that's the only symptom that you had, was a little rash, or you got some stiff joints or whatever. And the more I read about this thing, and the more concerned I started to become about the various symptoms that could be considered a possible case of Lyme disease. I started to read all the literature that was available. There were very few articles in newspapers back in 1985. It wasn't in style in those days. but I knew that we started to have a problem because I could see that if 2 occurred in 1 year, the chances are the ticks weren't going to go away. Neither was the disease. I saw no, unless there was a drastic change in climate or some other serious calamity that would kill off the ticks, that we were going to have a problem. So I started to pilfer wherever I could information on the topic of Lyme disease, written articles from the health department, the Vector Control Agency out in Suffolk County. And I put together, the Cooperative Extension was another source. I put together a brochure originally for our employees because at that time I didn't believe that the magnitude was going to be as much as it was, and secondarily for the public. My original concern was our employees. In addition to the brochure, which we print in-house, by the way, we also produced a poster, and this has a picture of the dog tick, not the deer tick. We produced a poster that basically was the same as what I received from the Cooperative Extension agent. And I received this in Nassau County from the agent, who happens to be a friend of mine. I tried to get additional copies because what I wanted to do was to put these at our park offices or park booths, any place where the public as well as our employees would look at, so that they could acquaint themselves at least on the subject of ticks as to how to avoid them and what kind of diseases these things carried. There was a very limited supply, I found out. So with our print shop at Babylon headquarters, we produced our own. Enough to paper whatever we wanted to put these things on. The Albany office became concerned about Lyme disease and ticks, and inasmuch as Westchester County was involved, and we had since then become involved with the New York State Health Department, Dr. Bosler and Dr. Banash and others, and with a lot of their cooperation, we have been in the process right now of producing a videotape. Much of the Army training material that you saw came from, well, in one case I saw an article, one of the brochures from Westchester County, which I have copies of. A lot of the information also came from sets of slides, which I too have borrowed from Dr. Bosler, and we are going to produce the video. Now this should help our employees, but it's not going to do a heck of a lot for the general public. What we found about these is that they are very fragile. When it rained, they would disappear very quickly. So we tried to figure out, well, how else can we alert the public besides handing out the brochures and posting these things? Well, from this sign, what we did is to develop another sign by a photo process. And these, in addition to the previous locations, have now been put on posts, and they are at entrances to the various trails from our parking areas. They are at the campgrounds. We don't give these things out to every person who comes through the park, because in Long Island, I'm not sure what the population of New York State is at the present time, whether it's 16 million, perhaps somebody knows here. But consider the fact that the visitation in Long Island State Parks is approximately what the population of New York State is for any particular year. And you can imagine what the magnitude if we gave one of these to everybody coming through a toll booth. So what we do is we have the signs telling them that they can acquire one of these brochures at the park office. So for those who have not read the multiple articles and many articles in the newspapers recently about Lyme disease, they can pick up one. There's less litter. We do require that at our park camp offices, and we have 3 camping parks in Suffolk County, none in Nassau. Each camper is given one of these and urged to read it. In addition, we have at several of our facilities a cooperative effort between BOCES and ourselves and other educational institutions which provide training for teachers and trips, wildlife trips, nature trips, and other kinds of outdoor types of education for the youngsters. Tonight, if anybody feels that the ticks are all gone for the rest of the year, don't be misled. I just had turned in within the past day or two some ticks that were taken off of youngsters in a BOCES program at one of our parks. What BOCES has done is before the kids go out, they're told what to look for, what to avoid, and that they were going to learn how to do checks out in the field, clothing checks, etc. Their parents are advised what to do when they get home, and so are the children. And that's where these ticks came from. To my knowledge, we haven't had any reported cases of Lyme disease among these youngsters. The employees that I'm concerned about, aside from the initial year of '85 and our subsequent training programs that we've been involved with, we are now up to between the 500 permanent, remember, and the approximately 1,800 to 2,000 seasonal employees. We have now 23 verified cases of Lyme disease. Of this 23 cases, 2 occurred the last week in September, first week in October of this year. 23. Of the two more of the 23 happened to be employees who were paid by the state of New York to assist Dr. Bosler and Dr. Banash with the research project, which is being conducted at Wildwood State Park and will probably continue for a number of years, assuming that the funding is going to be provided. How else can we reach the public? I'm at a loss to know, other than what we've been doing. One of the things that I can think of is that I'm not sure how effective a TV tape is going to be. If we can perhaps come up with somehow a 16 millimeter movie film sometime in the future, or we are in the process in Long Island. I have submitted the request to purchase a production of the television show 2020. I don't know, how many of you saw that production? Okay. Aside from political ramifications and length of time spent on various parts of it, I think it was an excellent production. I asked if I could use part of it for a training program, and I was told that no, it had to be used in entirety. So we are purchasing in entirety the 2020 production, which can be used for training. Now, in addition to our own TV thing, which we are doing, that will be a separate item which can be shown, but it can also be shown to campers, particularly if I can get this turned into a 16 millimeter production. We supply not only Long Island State Parks with these items that I talked about, and we also have a brochure without a lot of pictures, a brochure printed in Spanish, by the way, in red letters to use as a caution flag for folks. We provide the brochures for Taconic State Parks and the Palisades State Park Commission. I'm hoping that the disease does not go as far as I think it will in the future and head north, but I'm afraid that's wishful thinking. I believe it's already headed further towards the city from the east end of Suffolk through Suffolk County, because we have one Lyme disease victim at least in just about every one of our parks, with the exception of maybe 1 or 2 parks. The major portion, however, is out at Hither Hills and Montauk. The TV tape that we're producing involves basically a lot of the material that you saw here, as I indicated, some talk from me, some showing of so-called typical habitat with cautions that don't just rely on the fact that you weren't in typical habitat for these ticks to not have a tick attach itself to you. It goes into the precautions to take, what to do if you are bitten, etc. It also, as part of this tape, I have done an introduction to the folks about 2 individuals, and then I interviewed the individuals involved. One had a serious case of Lyme disease. One had a minor case of Lyme disease. The one with a minor case of Lyme disease also has a daughter who came down with Rocky Mountain spotted fever. So I'm trying to cover as many of the diseases with 2 interviews as possible, and I hope it will be successful, at least in getting the message across to our employees if they haven't already got it. One of the concerns that we have about seasonals, as opposed to the line item or permanent people, is the seasonals when they go away at the end of the year and back to school. It may take a month, 6 weeks, whatever it takes for this disease from the time that they were bitten to show some manifestations in the individual. We would hope that they would recognize that they got a problem and go to the doctor. What we've done to try to make sure that we have some kind of a handle as well on the number that do come down with this after they leave our employment is this year we have put in a slip of paper with their last paycheck advising them if they have any diseases or any symptoms that may not be normal to their normal physical feelings, go see the doctor, make sure he's aware of where you worked this past summer, and if necessary, the doctor can provide you with his recommendation as far as blood tests or whatever. But the doctor should know. On Long Island, hopefully, more and more doctors are getting to know, and in the short time, if there's anybody that's left that doesn't know about Lyme disease, I'd be very surprised. But the further away that you get from this problem, there is my concern. Traveling long distances away from these endemic areas could be a problem. With that, I will say thank you for your attention, and I'm finished. If you have any questions, I'll be happy to answer. Yes, ma'am.
Is that board your expenses to produce?
No, we buy large sheets. I couldn't give you the exact reproduction cost on it. No, it's very economical. If I went to metal type backing, it would not be as cheap. It's done by a photographic process, and they make a print from the photograph, and they produce a silk screen. And then these are done. Somebody paints the sign blank with a white roller. I can, if you want to leave your name with me, I can find out exactly what the process. Our people do this in-house. We have a shop. We have a photographer. We have a photographer. We also have a sign shop which does silk screen as well as other kind of. Yes, ma'am. I'm sorry, I can't hear you. Okay. Just a few years ago when I started, I said I started in '85 based upon a problem with two of our employees. And since then it's gotten a lot broader. But in my initial readings of literature, what I read was 32 or 33 states had the disease. Now I understand, Ed, is it 37 states or 38?
36.
Okay. So I think as more people learn to recognize this, maybe the reporting is getting better. I really don't know what the answer is, or else the tick is spreading.
Gloria, we have the State Health Department declared Douglas and Ulster endemic counties now. But we also did a survey in state parks in Douglas. That was 2 years ago. And we found absolutely no evidence in state parks. That's one. But, well, I know what's happening, but I mean, I think maybe we should reinitiate the upstate